Hello, welcome to the second class on protein energy malnutrition. So in the first class, I had talked about the etiology, the background, the pathophysiology, the determinants of protein energy malnutrition. So continuing on, moving on, in this class, I'll be dealing with the key features of marasmus and kwashiorkor, that is the two extremes of protein energy malnutrition, the classification of protein energy malnutrition based on the different classifying methods, and finally the control and prevention measures for protein energy malnutrition as a public health disease. So these are the topics like I will be talking about. Like I already talked about classification of the PEM, marasmus and kwashiorkor, some of the cardinal features and essential features of this end of the protein energy malnutrition and prevention and control measures. Now coming on to the classification of PEM. There are four main types of classification which should be known at the undergraduate level. They are Gomez classification, Waterloo's classification, IAP classification. IAP stands for Indian Academy of Pediatrics. It is the Association of Pediatricians in India. And finally, the arm circumference, that is the mid-arm circumference of the child. Now, why classification is important? Classification is important because by classifying the child into different grades of malnutrition, the prognosis and also the treatment modalities of the child can be fixed, and it is easier for maintaining the treatment, initiation of treatment. The first type of classification, Gomez classification. It's based on weight retardation. That is, there is a decrease in the weight expected, gain expected for a child of a particular age. It locates the child on the basis of his or her weight in comparison with a normal child of the same age. So what is a normal child? Normal child is, in this classification, the normal reference child is in the 50th centile of the Boston standards, where in a particular hospital, based on the admissions of children on malnourishment, the 50th centile of the children admitted is kept as a normal reference child. By using the weight for age, but one of the drawbacks of Gomez classification is by using the weight for age method, it is difficult to know whether the malnourishment or undernutrition is because either acute or chronic. So we can detect there is presence of undernutrition, but we cannot know whether it is acute or chronic undernutrition. So this is the formula for Gomez classification, that is weight for age. Weight for age in percentage is given by the formula of weight of the child in kgs divided by weight of a normal child of the same age, that is a reference child, like I said, which is a Boston standard, multiplied by 100. So by using this formula, we get a number in particular in a percentage. So that can be based on the table provided. The children are classified into various nutritional levels. If the nutrition level of if the weight for age percentage of the child is found to be between 90 to 110%, it is considered as a normal nutritional status. If it is between 75 to 89%, it is known as first degree or mild malnutrition. If it is less than that, that is, if it is between 60 and 74% of weight for age of the child, then it is second degree or moderate malnutrition. Like I talked about in the first lecture, most of the children, what we see in the clinically in the field, most of the child, 80% of the children, if they have malnutrition, if it is either mild or moderate, whereas the severe forms of malnutrition, such as kwashiorkor and marasmus, are rarely seen. So moving on, if the weight for age percentage is under 60%, anything less than 60% is considered as severe malnutrition or third degree malnutrition. So based on the nutritional status of the child, that is, if the child is either first degree or second degree or third degree malnutrition, different treatment modalities is present. Next, the Waterloo's classification. It defines two types of malnutrition. Again, I had talked about the terms which are commonly used by WHO in regard to protein energy malnutrition or malnutrition in general. That is stunting and wasting. Stunting is nothing but got by the formula height for age, whereas wasting is obtained by knowing the weight for height of the child. That is, stunting is more indicative of chronic malnutrition, whereas wasting is more indicative of acute malnutrition. That is maybe some episode of infection, diarrheal disease or helminthic infections, and thereby there is an acute case of malnutrition. Height for age percentage is got by the formula of height of the child divided by height of the normal child at the same age multiplied by 100. So again, by comparing the height of the child to a normal expected norms of the child at the same age, you get a height for age of the child. A drop in this ratio, like I said, indicates stunting or chronic malnutrition. Next, moving on to wasting. How can wasting be estimated? Wasting is estimated by the formula weight for height. Again, that is given by the formula of weight of the child divided by weight of a normal child at the same height multiplied by 100. Again, a drop in this ratio indicates wasting or acute malnutrition. So height for age and weight for height are respectively used for estimating the stunting and wasting in children. This is the classification of the nutritional status based on either whether the child is stunted or there is wasting. If it is if the nutritional status, if it is more than 95% based on the formula, then it is normal. If it is between 87.5 to 95%, then it is mild malnutrition. If it is between 80 to 87.5%, it is moderate malnutrition, that is with regard to stunting. Then if it is severe malnutrition, when it is less than 80%, that is for stunting, that is height for age percentage. Whereas moving on to wasting, if it is more than 90%, it is considered as normal. 80 to 89%, it is considered as mild malnutrition. 80 to 90% is considered as mild malnutrition. 70 to 79%, there's a mistake here, 70 to 79% is considered as moderate malnutrition. Anything less than 70 is known as severe malnutrition with respect to wasting, that is weight for height. Moving on to the next type of classification, that is IAP, that is the Indian Academy of Pediatrics classification. It is based on weight for age. Again, it is calculated by the same formula like what I told. Weight for age percentage is weight of the child divided by weight of a normal child for that age multiplied by 100. So by using that formula, if the percentage is found to be between 80 to 100%, it is termed as a normal nutritional status. If it is between 70 to 79%, it is grade 1 or mild malnutrition. 69 to 60%, it is called as grade 2 or moderate malnutrition. 59 to 50%, it is known as grade 3 or severe malnutrition, and anything less than 50%, it is termed as grade 4 or very severe malnutrition. Okay, moving on to the last type of classification, which is commonly used in the field in the public health system of India, that is the mid-arm circumference or arm circumference. It is also the type of classification which is relied on by the WHO, which is easy to administer at the field level. It gives a reliable estimation of the body's muscle mass, because it is estimated that between the age of 1 to 5 years, the muscle mass at the arm of children will be at a reasonably stable level. It cannot be used for children less than 1 year, and it cannot be used for children more than 5 years. So between 1 to 5 years of age group of children, it can be used. It is measured by using a tape that is at the mid-arm circumference. Again, based on the reading, if it is more than 13.5 centimeters, it is considered the nutritional status of a child is considered to be normal. If it is between 12.5 to 13.5 centimeter, it is considered as mild to moderate malnutrition. Anything less than 12.5 centimeter is termed as severe malnutrition. So this is a very easy classification as compared to the other classifications. That is why it is the most commonly used one in the field. Now the picture on the right hand side shows the tape which is used. This is a tape which is used to monitor the malnutrition or the nutrition levels in children between the age group of 1 to 5 years. Here you can see there are different colors being used. The one is the red color. Red indicates that when it is less than 12.5, it is severe malnutrition. Then there is green. Green indicates it is normal level, that is above 13.5. And there is also a yellow color in between, which comes in between the red and the green, that indicates mild to moderate malnutrition. On the left hand side, you can see the picture of a child whose mid-arm circumference is being measured. So since it is color coded, it is even more easier for the peripheral level health workers such as ASHA workers or A&M workers who go to the field and measure the children at the household level or at the Anganwadis. So that was about the classification of PEM. Now moving on to some of the features, that is clinical features of marasmus and kwashiorkor, which are the two severe forms of malnutrition, protein energy malnutrition. Moving on to marasmus, you can see the picture of the child here. The common features with marasmus is severe wasting of the muscle and subcutaneous fats. There is severe growth retardation. But unlike kwashiorkor, in marasmus there is no edema or hair changes or fatty liver. The child is alert but miserable and hungry. So these are the features of child with who is marasmic. Moving on to kwashiorkor, the cardinal features of kwashiorkor are, as you can see in the picture, this is the picture of a child having kwashiorkor. The cardinal features are, that means the features which are always present: edema, psychomotor changes, growth retardation, and muscle wasting. So muscle wasting is seen in both, but edema is seen only in kwashiorkor. Some of the associated features of kwashiorkor are moon phases, hair changes, skin changes, depigmentation, edema, hepatomegaly, flaky pain, dermatitis, cardiac failure, dehydration, and vitamin deficiencies. So you can see in kwashiorkor, along with the cardinal features, there is a long list of associated features which are seen in, also which may be seen in kwashiorkor. Now finally moving on to the public health aspect of PEM, that is the prevention and control. Since I talked about the prevention, the epidemiology of prevention in the first lecture, the PEM is a public health problem in India. It accounts for a large chunk of morbidity and mortality of children in the below 6 age group. So the different steps of prevention are, like it has already been discussed in the basic epidemiology classes, that is primary prevention, secondary and tertiary prevention. Now within primary prevention, the one method is called as health promotion, where the health is promoted. That is, before the disease has occurred, you improve the health of the child so as that the protein energy malnutrition does not occur. Now what are the steps within health promotion? One is the measures directed to pregnant and lactating women. That is, by educating either the pregnant women and the lactating women about the importance of breastfeeding, about the importance of complementary feeds, about till up to what age breastfeeding should be continued, when complementary feeding should be started, all that. And also about distribution of it is also about distribution of food supplements. That is, food supplements are provided to the pregnant and lactating mothers and also children between the age group of 6 months to 5 years at the Anganwadis. Then promotion of breastfeeding. Breastfeeding is important. That is, exclusive breastfeeding for the first 6 months and then continued breastfeeding along with the complementary feeds for up to 2 years of age. That has to be promoted among the mothers. Then development of low-cost weaning foods. Because ours is a developing nation, there is a large amount of chunk of the population in which the malnutrition is more common as compared to the upper socioeconomic group, for whom access of food is limited because of the socioeconomic reasons. So development of low-cost weaning foods will be helpful in promoting the health of the children. Then measures to improve the family diet. That is, the overall diet of the family is improved by giving the health education to the parents. Then nutrition education to promote correct feeding practices. Again, the nutritional education is provided to the pregnant lactating women and also to adults and girls, so that when they get older, get married and have children, they know the right basics of the good nutrition for the child. Then home economics, that is improving the home economics, improving the socioeconomic condition of the homes, thereby improving the access to nutritious food and thereby decreasing the prevalence of malnutrition. Then family planning and spacing of births. Family planning is very important. The pregnant women, the lactating women, the adolescent girls, the married women in the married groups They are educated about the importance of family planning, what are the various methods to implement family planning, be it either the temporary or the permanent methods, and also spacing of births. That is, at least the mothers, the lactating mothers or the pregnant women should be educated about the importance of spacing of birth. There should be at least 3 years of gap between each birth, so that there is enough amount of time for the redevelopment of the nutritional status of the mother. That in turn will affect the nutritional status of the newborn child. And finally, family environment. Family environment means improving the sanitation levels, hygiene levels in and around the house, so that there is decreased chances of infection in the child and thereby decreased chances of malnutrition. So that was about health promotion. Next, the second measure within primary prevention is specific protection. That is, specific measures are used so as to protect the child of the protect health of the child. The first one being the child's diet must contain enough amount of protein and energy-rich foods. So foods which are rich in proteins such as milk, eggs, fresh fruits, groundnut, they should be such food should be promoted for among the usage among the children, so thereby health education has to be provided to the mothers. Next is immunization, that is immunization against preventable diseases and thereby controlling the infections and thereby decreasing the rates of malnutrition. Finally, food fortification. Food fortification is nothing but addition of micronutrients to commonly used food articles, such as addition of vitamin A, vitamin D or vitamin B, or also iron and iodine, which is commonly, these are the nutrients which are commonly used as fortificants along the commonly used food articles. Example, the commonly used food articles which are used for food fortification are maybe common salt or the sugar. It has been tried in various nations. Example, in India you have fortification of common salt with iodine to prevent iodine deficiency disorders, and also with iron to prevent iron deficiency anemia. That was about the primary prevention. Now moving on to secondary prevention. Secondary prevention is nothing but by early diagnosis and treatment of the condition of malnutrition in the child, thereby preventing the condition into getting into severe forms, and thereby preventing the morbidity and decreasing the mortality, and preventing the severe complications. The different measures within this are periodic surveillance, that is periodic community surveillance is undertaken in the field to where the growth of the child is monitored, and anything if there is a lag in the growth, it is immediately noted down and the child is evaluated for the causes of malnutrition and thereby treated accordingly. Then early diagnosis and treatment of infections. If there's any infection, if like diarrheal diseases or helminthic infections or GIT infections, their early diagnosis is made and they are treated accordingly. Then development of programs for early rehydration of children with diarrhea. As you know, for diarrhea, the most common, most cost-effective method to prevent deaths due to diarrhea in the children is also in adults is by using oral rehydration solutions. So the mothers are taught about how to prepare ORS if they don't have access to ORS packets at home, that is by using salt and sugar and drinking water. Also, they are taught about when it should be used, what is the dosing, and also ORS packets are provided at all the public health centers, which can be used to prevent deaths due to diarrhea. Then development of supplementary feeding programs during epidemics. That is like the epidemics. What we are going through now. In such situations, there is a shortage of food articles, especially for the low socioeconomic group who all deal with hand-to-mouth sustenance. They have difficult to access to food, and thereby the children might get malnourished if it is a prolonged period of epidemic. In such during such periods of epidemics, food supplementation has to be provided, which is being provided either to the government schools or the Anganwadis, also through primary health centers. Finally, deworming of heavily infested children, that is, children who are heavily infested with helminthic infections, deworming is done. Children in government schools are biannually dewormed by using albendazole tablet. The dosage is 200 milligram for children less than 2 years and 400 milligram for children older than 2 years, thereby to deworm the child and prevent helminthic infections and thereby prevent malnutrition. Finally, the last part about the prevention aspect, that is the tertiary prevention. That is, the disease has occurred, it was not detected in the early stages, and it has gone, the complications are so as not to prevent the complications. Tertiary prevention measures are taken up. What is them? They contain rehabilitation, that is nutritional rehabilitation services. Nutritional rehabilitation centers, NRCs, are set up in the at the district level. These are specialized centers where children with malnutrition, that is severe form of malnutrition such as maybe kwashiorkor, marasmus, who have grade 3, grade 4 malnutrition, are admitted. Their growth is monitored. They are given additional supplementary nutrition if they have any infection that is treated, or any other underlying cause, medical condition which is leading to the malnutrition, that is diagnosed and treated accordingly. And once the child, the medical condition of the child is treated, and the child is gaining weight up to satisfactory level, and growth of the child is again back to the expected levels, then the child is discharged. And after discharge, again the follow-up care is done for the child, where the ASHA, the Anganwadi workers, they visit or the ANMs, they visit the child at home so that the growth is monitored. Next is hospital treatment, that is again for severe forms of malnutrition. If there is recurrent diarrhea, severe malnutrition, then again the child has to be admitted and treated accordingly. And follow-up care. Follow-up care is done by the peripheral healthcare workers. Like I said, the ASHA workers, the ANMs, they visit the homes, they follow up for the children who are discharged from the hospitals or the nutritional rehabilitation centers, so that their growth is monitored, so that they do not fall back again into malnutrition, and thereby the child can gain adequate weight. Okay, so that was about the PEM, that is the prevention and control aspect, the classification of it, and some of the clinical features of kwashiorkor and marasmus. Thank you very much.